Can we go to the next the talk that is by Dr. Mihir Trilok. He's AIOS Hanumantha Reddy Award winner. He's going to talk about accommodation scale, a ruler gauge for objective assessment of magnitude of accommodation in kids.
Thank you very much for paying attention to this repeat presentation of an accommodation scale. I'm glad to inform you, last month it was presented at American Academy of Pediatric Ophthalmology and Strabismus. This is a scale which you could use to assess the quantity and quality of accommodation of pre-verbal children as young as 6 months of age. I have no financial disclosures to make. It is not uncommon to see accommodative abnormalities in various ocular disorders affecting children, such as Down syndrome, cerebral visual impairment, foveal hypoplasia, children suffering from ectopia lentis, and of course those who have suffered from amblyopia or various strabismic disorders with abnormal AC by A ratios, children with headache, and children who are on low dose atropine to control their progressive myopia. All of them will have abnormal accommodation in as many as around 50 to 80% situations. Currently, the objective methods available are dynamic abrometry and open field autorefractometry, which are not very clinical, they are research based methods. While dynamic retinoscopy is the gold standard, which is used by most pediatric eye surgeons across the world. Unfortunately, this technique has difficulties. Learning is also difficult, and having child's attention to do an adequate examination is also difficult. In our survey of 18 pediatric eye surgeons of Mumbai, only one of the pediatric ophthalmologists was confident enough of quantitative assessment of accommodation using dynamic retinoscopy. So a few years back, we worked on a new technique, which is using a direct ophthalmoscope, ask the child to look at a distance object, and then ask to look at a 40 centimeter object, which is slowly approaching the eye up to 25 centimeter, while the ophthalmoscope is held at meters distance. What you will see in the pupil is an disappearance of a superior bright crescent and appearance of a large inferior crescent as the object of interest approaches the child's eye. This is quite well demonstrated in this particular video, in which when the child is looking at distance, the crescent is superior, and the bright crescent suddenly changes to an inferior bright crescent, and the size of that crescent keeps increasing as the child keeps increasing its accommodation. 1,000 patients data was published in Indian Journal of Ophthalmology in 2014, and then again around 1,000 data points were published using more advanced technique of performing this same thing using a neutralization method with lens interjection. As you see over here, when the child is looking at 40 centimeter and there is an inferior crescent, you can neutralize it with minus 0.5 diopter, and while looking the same child at 25 centimeter, you could neutralize it with 3.5 diopter, indicating the amount of accommodation child is exerting. So in this study, we wanted to create a scale and then validate it. The scale was created like this. The child was, emmetropic child was asked to look at a distance, a 10-year-old child, and lens interjection was done to simulate the amount of accommodation that will be exerted using 0.5 increment of plus lenses. And it allowed us to create this kind of a scale as you see over here. And in the past, ophthalmology has seen multiple such scales, such as pupil gauge or the gauge for cup disc ratio, AV ratio, etc. We had to have 15 patients in our sample for 80% power of the study and 5% significance level. We included 5 to 16-year-old children with normal ocular and systemic health. Our pediatric oriented optometrist first performed this technique, which we coined as estimation dynamic distance direct ophthalmoscopy using accommodation scale and minimal estimation method, which is a dynamic retinoscopy method. And when we compared, we found accommodation scale to have better values at 33 and 25 centimeter versus the current gold standard, and correlation coefficient was excellent between two techniques. We also validated the same scale among pediatric eye surgeons of the city, and we found at the end of the validation, most say 16 out of 18 members were able to confidently assess using this particular scale. The only limitation I find with this particular method is it is still derived from lens interjection method, and using an app based evaluation like GCK app could make it easier. So in conclusion, accommodation scale is a new armamentarium available in measurement of accommodation for children, and it's quite quantitative and qualitative assessment technique for binocular assessment of accommodation in children. Thank you very much for your attention.